We are recording.
Well, welcome, doctors. Dr. Robert Fennell here on your CHA webinar. Today we're going to talk about a topic doctors bring up quite often, both newer doctors that are just getting started in their practices or graduating from chiropractic college and getting started in their practice, or doctors who maybe want to take a little bit different pathway in their practice. They've been practicing for 10 or 15 or 20 years, and maybe they've been all cash, but they've seen more networks come into the area, and as a result, maybe their patient volume has gone down a bit, and they want to think about getting into network with some of the networks, but not sure where they should go and where they should stay away from. Or doctors that are already in network with all the companies out there, network providers, and they're treating a lot of patients and getting very poor reimbursement, and they're not sure kind of when to drop out of some, and they don't want to make the wrong decision too early. So in either case, this will be a really good webinar. Our guest today presenting is Lisa Majeski. I almost said Dr. Lisa Majeski, but I almost feel like you're a doctor as much as I've talked to you over the years and known you and worked with you on just chiropractic things in general. But Lisa has a lot of head knowledge, a lot of book knowledge, but here's the good thing. She's got a lot of real world experience behind that knowledge and helping clients and doing medical and chiropractic insurance billing. Her company is called Gold Star Medical. They're out of San Angelo, Texas. You can find her online at goldstarmedical.net. Phenomenal company. She does the billing and collections for my chiropractic office, and some of our clients use her. So if you're looking to outsource your billing or even a part of your billing, make Lisa one of the first resources you call. She'll do a consultation with you and talk about your needs and get you set up. But she likes to educate. That's what I love about her. So Lisa, thank you for being on here with us today, and I'll go ahead and give you the microphone, so to speak, and I'm looking forward to hearing what you have to say about this topic.
Thanks a lot, Dr. Fennell. I sure appreciate that introduction. I'm going to put everybody on mute, at least for now, and then when we are at the conclusion of the presentation, I'll open it up for questions. Also, in your menu, in your GoToMeeting menu, there's a chat box. So if you do have a question off the top of your head and you don't want to forget the question for the end of the presentation, you can type it into the chat box, and I'll use the chat box to address any questions that come up. So as Dr. Fennell said, today's presentation is called To Participate or Not, How to Decide If You Want to Play the Insurance Game and With Whom. And as Dr. Fennell mentioned, the decision as to whether you would like to participate on a particular insurance plan or not is a very, very personal one. And as a result, one of the things about this particular presentation that I do want to let you know is that I do inject a little bit of opinion in this particular presentation. In my opinion, it comes from years and years of experience in the chiropractic field and in the medical field in general with respect to certain insurance plans and whether it's a good idea or not. Now, I'm going to try to be as factual as possible, but my disclaimer for today is that there may be some opinion in here that you would need to decide if you would want to follow. These recommendations should be adopted at the sole discretion of you, the provider, or your facility. And also remember that before entering into any contract with an insurance plan, I believe that it's advisable to seek the legal counsel of a healthcare attorney in your state. Number one, to make sure that the insurance contract that you're entering into is one that you can live with and one that is not going to be so restrictive and so long term that you're going to get yourself into something you can't get out of easily. So those are my two disclaimers. Now, today, our course objectives are going to be to discuss the different types of insurance plans that are out there in which you can participate, the differences between being an in-network versus an out-of-network provider. We're going to talk about how you can analyze the cost of doing business with an insurance plan and whether that insurance plan is actually worth getting involved in or not. And there are many, many variables that take place when you're making this kind of an analysis. The other thing we need to talk about is how to choose the plans in your area, because there may be insurance plans that are sending you solicitations that may not even really be relevant for the area in which you practice. We'll discuss the art of negotiating contracts, and we'll have a short discussion on the credentialing process. So let's go ahead and get started right away. As you can see on your screen here, there are a number of different types of insurance plans that you as a provider can get involved with. We have government plans, which are represented by Medicare, Medicaid, TRICARE, the VA, and you have different types of commercial plans, which are plans that can be self-insured by an employer, HMOs, PPOs, and so on and so forth. And some examples of commercial insurance plans are Blue Cross Blue Shield, United Healthcare, Aetna, Humana, Cigna, and so on and so forth. Now, for the purpose of today's presentation, I've highlighted the items and the topics of the plans in yellow that would represent the main topic for today's presentation. Obviously, in the short hour, 45 minutes to an hour that we don't have time to really discuss the participation of all of these types of plans, but hopefully what we'll do is we'll cover the ones that would represent 90% or more of the plans that you would participate in with your practice. So let's talk about a little bit of detail on these government plans that you may consider joining as an in-network provider. Of course, we have Medicare, and Medicare is a nationwide health insurance program for persons ages 65 and older, and certain people who are on disability or blind persons regardless of income. So there's no income requirement or an income threshold to be Medicare eligible. It is based on age, and it is based on, in part, if you suffer a disability that you are awarded Social Security disability benefits. Medicaid, on the other hand, is a federally aided and state-operated program that provides medical benefits for certain low-income persons in need of health or medical care. And since in this particular presentation we're talking to chiropractors, some states do cover chiropractic services under their Medicaid plans and some don't. And since I am not aware of the different states that are represented in this webinar, since Chiropractic Hand and Foot Clinics of America is a national program, there may be some of you who actually would consider signing on as a Medicaid provider, and so we want to discuss that. TRICARE is a federally funded health program of the U.S. Department of Defense that provides beneficiaries with medical care supplemental to that available in military and public health service facilities. And then the VA is America's largest integrated health system, providing care at 1,240 different healthcare facilities throughout the United States, including 170 medical centers and over 1,000 outpatient sites of care of varying complexity, serving 9 million enrolled veterans each year. And years ago, the chiropractic benefits for veterans was extremely limited, if available at all, and you had to get special dispensation. But that's changed over the years, and now chiropractic services are available to veterans, and so that is an area in which you would need to decide if you would want to participate. Just to mention, we're not really going to talk about this too much today, but I did want to also bring to your attention that you could decide to become a provider in a workers' compensation plan. Every state has different requirements as to workers' comp laws, how favorable they are for chiropractic care. And so if you are interested in maybe being a work comp provider, that would probably be an individual consultation with me. You can certainly give me a call and we can discuss the pros and cons of that, as well as the pros and cons of getting a higher presence and a higher involvement in personal injury claims and in auto PIP. Also, under this umbrella, we also have the liability policies, such as homeowners insurance and business liability policies. We're really not going to have time to discuss these today, but it certainly is a topic that I'm available to you on a one-on-one basis to talk about. let's talk about the commercial insurance plans. Now, commercial plans are a type of health insurance that covers medical expense and disability income for insured people. It is usually provided and either fully or partially funded by an employer or a special group or organization. And a great example of a group or an organization that might provide group health care would be AARP. AARP is one of the largest providers of supplemental Medicare insurance, and it is provided as a group. The group is AARP, so it's not an employer, but as a group, the group has the ability, because of the number of members that it has, to offer lower premiums to the beneficiaries. And so, again, you have, under the commercial plans, you have group, and you also have special group or organization plans. Sometimes commercial plans can be purchased individually. So, for example, I'll use myself. I'm a self-employed business owner, and so I'm not tied to an employee group. I have to purchase my insurance individually. If I wanted to, I could get involved with a special group such as the National Association for Self-Employeds, and they do have group health plans under that association. Sometimes your chiropractic state association or your medical state association will have group health plans available for the providers that are members of that state association. So those are types of things that you could look into. Under the commercial plans, most commercial health plans fall under the definition of a managed care organization, and under the managed care umbrella, you have different types of managed care plans. You have preferred provider organizations, HMOs, point of service plans, and exclusive provider organizations. Now, the differences in these types of plans really lies in a few things. Number one, in the restrictions that patients have in choosing the provider of their choice, and in the out-of-pocket costs and premium costs for the beneficiaries or the patients. So, for example, under a preferred provider organization, the patient usually has the ability to choose whether they would like to be see an in-network provider or an out-of-network provider. And they have that choice. So if you are, let's say, an out-of-network provider, the patient chooses to see you as an out-of-network provider, they will receive medical benefits. However, the medical benefits will be reduced. Instead of having a $25 copay for their medical service, they may have to pay a $1,000 deductible and then have a coinsurance of 70% or 70-30. And so while they can receive the care is going to be a higher out-of-pocket cost to them. The HMO plans are much more restrictive. I call these all or nothing plans. So if you are a provider under an HMO, the good news is that the patients will have a very limited list of providers that they can see. So it could give you a great influx of new patients as a provider under an HMO. However, there are usually a lot of restrictions tied to HMO plans, such as a specialist. So as a chiropractor, you would be, in many states, you're considered a specialist and not primary care. And in that case, what would happen is the patient would have to get a referral from their primary care doctor in order to see you, even though you are a provider under that plan. And so again, when we're going to talk about these types of considerations, when we're looking at the contracts themselves, the point of service plans are very rare. Those are the old plans that, a patient can see anybody they want at any time, and when you bill out the services, you get paid exactly dollar for dollar for the services you bill out. These are becoming very rare. So the point of service plans really don't apply very much, and I would be surprised if anybody really came across a POS plan in your area. And if you do, you're very lucky, because POS plans still pay very, very well. And then the EPOs, your exclusive provider organizations, these are usually tied to hospital groups where the doctors are attached to a hospital, and the patients, if they have insurance and they have insurance that directs them to that hospital for hospital services, would have to see any provider that would be listed under that plan. So it's very, very similar to an HMO in that respect. So we talked about the plans, but within each plan, you as the provider have the opportunity to choose to be in network with a plan or out of network with a plan, to participate or not to participate. And so let's talk about what it means to be in network with a plan. So if you are in network with an insurance plan, and that can be an HMO or a PPO or Medicare or Medicaid, or the VA, you would choose to be in network. You would contract with that insurance plan. So that means that you come to an agreement with that insurance plan to be a participating provider. The term of the plan can be a yearly term or a mutually perpetual plan, which means that once you're in network, they will assume you to be in network for as long as you choose to be or they choose to have you. The provider or the organization would agree to operate under the terms of the contract, and you agree to accept assignment, and you agree to bill claims on behalf of the patient regardless of the patient's benefits. So as an in-network provider, you may have a patient that comes to you with a $5,000 deductible. Now, you know, for chiropractic services, it's very unlikely that if all they do is go to see the chiropractor, that they're going to meet their deductible. But that does not alleviate the responsibility that you would have to bill the claims out on behalf of the patient. You still have to do that. Now, there are some workarounds, such as a waiver to file insurance that a patient can sign stating that they're waiving their right to have you file the insurance. And that is something that we could, if you ever needed advice on that, we could certainly discuss that. The pros to being in network on insurance plans is that, number one, is that you're on the list. So for those of you who are looking for new patients, who are looking to build your practice, and you're new in practice, or you've had a few bad years of new patients, and you really want to boost your new patient numbers. It is definitely a pro to be on the list, because patients the first thing they'll do is, when they're looking for a doctor in their area, they're going to go to their payer's website and search for a doctor, search for a chiropractor. And if you're on the list, the patients are going to be looking for doctors in their plan first. And even if they call, let's say they called Blue Cross Blue Shield, Blue Cross Blue Shield would direct them to a place where they could look for doctors who are on the list. So it is definitely a way for you to generate new patients, and it could be significant depending on the employers that are in your area and the plans and the number of employees that are represented on the plans that you wish to get in network with. The other pro is that the bulk of the payment is going to come from the payer. The patient portion, generally, unless they have high deductible plans, are going to be minimal compared to the amount of money you get from the payer. You will also get reimbursed faster. Electronic billing and electronic filing and ERAs and EFTs checks that go directly into your bank account. In many cases, for example, if you're in network with Aetna, you're usually paid in 3 days if you electronically file as an in-network provider. And as an in-network provider, one of the things that you have the ability to do is track and analyze your production within that network. And so sometimes the payers will provide those analytics for you. Sometimes there are reports that you can run. You may request analytics from your provider relations representative, and they will produce those analytics for you and discuss ways that you can be more profitable. And so there are a lot of pros to being in network. Now, on the flip side, there are some cons. And the cons are that you have to abide by the contract. And what I mean by that is you have to color between the lines. So Each contract is going to have specifications on how you are to practice. They usually will come with medical policies for numbers of visits that you can have, whether there are authorizations necessary, whether you have to get pre-authorizations for services. There may be a cap on the dollar amount that you'll get reimbursed that is represented by the fee schedule that you would have to abide by. And so those are some of the provisions of the contracts that you may or may not want to live with. And being a network with an insurance carrier may increase administration costs in a number of ways, and we're going to talk about that as we discuss the analyzation of whether to be in network or not. Now, as an out-of-network provider, you do not have a contract with your insurance plan. So what that means is you don't have to accept assignment. You don't have to bill claims for the patients. You don't have to take discounts on your billed fees. That all sounds very good, okay? And a lot of doctors think, you know, that's really the way I want to operate. I want to just have a simple practice in which my fee is my fee is my fee. I don't take discounts on my fee. If the patient wants to turn their insurance in themselves, that's fine. I'll give them a walkout statement and they can file the claims themselves. And, you know, and I don't have to take those discounts on those fees. The pros to that is that the bulk of the payment is going to come from the patient, which means that you can get paid at the time of service. You can choose whether you want to bill the claims for the patient or not, because now it's a courtesy and not a contract. And because you are not required to bill on behalf of the patient, it could significantly reduce administrative costs and lower your overhead to keep fees reasonable. Now, the cons, again, on the flip side, you're not on the list, and the payers will be encouraging patients to see doctors who are on the list. So if you're not on the list, don't expect any help from the payer in bringing patients to your office. Now, if you're not worried about that, then that's okay. And the other thing that you need to understand is while it may reduce administrative costs to be out of network, it doesn't always do that. And the reason why that is because sometimes what I see with providers who are out of network is that they want to, what I call, straddle the fence, which means you want the best of both worlds. You like the pros of being able to bill your full fee for service and collect the full amount, but you are hesitant about asking for the patient for all of that money up front, because it is more likely that the patient is not going to stay with you for a long-term care if they're having to pay much higher costs out of their pocket. And so what I see many providers do who choose to be out of network is they agree to file the claims for the patient, okay? And so whether you accept assignment or not, you agree to file the claims as a courtesy. So what happens is, since you're agreeing to file the claims, if there's a problem with the claim, the patient is still going to look to you for results. And it's very hard for a provider to say, well, I'm just going to file the claims, but after that, I wash my hands of it. If you have a problem with the claim, that's on you. That just doesn't happen. You know, it will almost always happen that if you're filing claims for the patient as an out-of-network provider, then, and there's something wrong, the patient is going to bring that EOB back to you and say, what do we need to do about this? And what they're meaning is, what are you going to do about this? Okay. The other problem with filing on behalf of the patient is that the payer has no contract with you, which means they have no obligation whatsoever to inform you of the adjudication of the claim. And in many cases, as an out-of-network provider, the patient gets the EOB and that's it. So now I want you to think about this in terms of the next area of danger if you're straddling the fence, which is that you're out of network, but you're also accepting assignment. okay, which means you are waiting for the insurance company to pay you and you are deferring the patient payment. Now, you, as an out-of-network provider that accepts assignment, you can still bill your full fee for service and you don't have to take the discount. But the problem is that, again, the payer has no contract with the provider, which means they're not obligated to honor that assignment of benefits. They can send the patient the check, which means now you have seen a patient, you have not collected the patient portion, you are billing the insurance company is sending the patient the money, and now you're having to chase the patient for the money. And you may not even know if the patient has been paid because the payer does not have an obligation to send you an EOB. And this is, by the way, for any of you who bill Blue Cross Blue Shield, almost every state in the United States for Blue Cross Blue Shield, if you are out of network, you are not going to receive an EOB from Blue Cross Blue Shield, whether you accept assignment or not, okay? And in most states, Blue Cross Blue Shield will not pay the provider. They will pay the patient, which means you have to collect all your money up front from the patient, give the patient a walkout statement, or go ahead and bill it for them, but you've collected all your money and now you're done. So you're done with that claim. So you have to really think about whether, when you're an out-of-network provider, am I really, really willing to be all in or all out? And I believe that you shouldn't straddle the fence. I honestly believe that straddling the fence and being out of network but billing insurance for the patient and accepting assignment for the patient causes more administration for you, more cost for you, and more leakage of revenue than being an in-network provider and taking the discount. I think you lose more money out of network if you straddle the fence. I think you should be all in or all out. And again, this is where my opinion comes in. You can take it for what it's worth, but this is what I have seen historically throughout my career with doctors who tell me, well, I'm out of network with all of these plans, and then they call on us to do their billing for them. I'm thinking, now wait a second, we're doing billing for plans that you're out of network with. You're paying us to submit claims that you're not even going to get reimbursed for. So you're losing money. I mean, if you think about it that way. So I think that if you are out of network, you should be prepared to advise the patients, number one, of your decision not to participate in the plan, and that, or advise the patients that you do not participate already. Collect 100% of your fee up front. Discontinue filing claims. Give the patient a walkout statement in which they can file the claims themselves, and follow the same billing and collection guidelines for all plans in which you don't participate. So you don't pick and choose because, say, all right, well, Aetna will pay me, but Blue Cross won't. So I will give the Blue Cross patients a walkout statement, but I will courtesy bill Aetna patients. Well, what happens if that Aetna patient now goes on with a new employer, and that employer has Blue Cross Blue Shield, and now you're telling your patients you can no longer bill? I don't believe that it is a good idea to have it one way for certain plans and another way for certain plans. So the question that I'm going to ask you, if you decide to be out of network on a particular insurance plan, is, are you straddling the fence, or are you all in with being out of network? So this is just an example of a letter that you could send patients if you do decide to get out of network with a certain insurance plan. You can post this also at the front desk, and it basically says that this is to notify you that we'll no longer be participating as a provider in the name of this plan. This is due in part to the increased restrictions the payer is placing on patient care and the increased out-of-pocket costs of the payer of Blue Cross Blue Shield patients. And so you can read this, and what it does is it couches it in a way that helps the patient understand that the reason why you are that you are getting out of network is so that you can actually deliver a higher quality of patient care. Because it is true that sometimes if you are in network with a certain plan, you may be restricted to the point where you feel like you cannot treat the patient to the highest level of medical responsibility as a doctor. And if you feel that way, then you may have to be out of network because the insurance company is placing restrictions on you that are too high and that do not allow you to render the highest quality of patient care to your patients. And so this is what this note would refer to. Now, some financial considerations on whether to participate or not participate in an insurance plan would be several. So number one is how are you compensated? So for example, are you going to be compensated by service code? So a 98941 is worth this much money, and a 97110 is worth this much money on the fee schedule, or is there a capitation? So, for example, United Healthcare throughout the United States now, it started in Texas and has now moved to all 50 states. United Healthcare is on a per diem plan, meaning there is a daily capitation. So I'm not sure about Oklahoma, but Texas, the per diem is $65, which means that a chiropractor can, in network with United Healthcare, can treat a patient, have a spinal manipulation. The patient can go in and have, let's say, 2 units of rehab. And maybe have a re-exam, and the total cost of those services is about $200. The most that the chiropractor will get paid is $65, no matter how much service is done. And that $65 is a combination of patient and insurance money. So if the patient has for example, a $40 copay for specialty care, then you would be billing $200 to United Healthcare. You would be getting a $65 cap, which means you would receive $40 from the patient for their copay, $25 from the insurance company for a $200 bill. You're going to have to ask yourself if that's worth it or not. And if you're a fairly straight chiropractor and you don't do much therapy, you don't do many ancillary services, that $65 is not bad. But if you're a functional medicine provider, that might be too restrictive. And so are there any types of withholds? Do you have any pay for performance requirements, like certain types of measures that you need to attest to in order for you to receive pay increases by that particular plan? What is the billing and collection process? What are your timely filing requirements and the insurance provider's reimbursement history and timeliness of payments? Is interest charged or earned for payment delays? And are referrals and pre-authorizations routinely required? Obviously, all of this is going to end up costing you some money depending on the level that you're going to be entering into with respect to these contracts. And then finally, how is this going to affect your overhead? What will be the administrative impact on the practice if you choose to participate? What is it going to cost you to do billing and tracking of claims? What is it going to cost you, the provider, in documentation requirements and time? Keeping up with referrals, if this is a type of plan in which referrals are routinely required. What is the potential influx of the new patient population? And sometimes you have to look at that and weigh that against the other elements of the administrative impact and the effect on the cost per patient visit. So other non-financial considerations would be, how are terminations defined in the contract? Is this something that if you get involved in and you find that this plan is too restrictive, that you're going to have a hard time withdrawing from? Are you going to be locked into at least a year term? Or is this something where you can get in network, and if you find that this is just not for you, that you can get out with a 90-day notice or a 60-day written notice? How can the agreement be terminated? Can it be terminated by either party? Usually it can. And what type of time is required to give notice? What are the grounds for the third party payer to terminate with you, and how much notice do they have to give you? What are the requirements for accepting new patients? If you're at a point where you're no longer accepting new patients, which very few chiropractic offices have ever been there, but there are definitely medical offices in which you get so busy that you discontinue accepting new patients. And if that's the case, that may be a reason for the payer to remove you from the plan as a participating provider, because one of the requirements of your contract is that you accept new patients. What is the level of provider risk and the ease for which you can be credentialed? So these are some other considerations that you want to look at when you're trying to decide whether to be in network or out of network with certain plans. The other thing that you want to analyze before you ever make a decision about being in network or out of network with a plan is, I believe that you really need to have a good handle on your cost of doing business. In other words, the cost per patient visit. So when deciding on the insurance plans that you want to participate with, a good benchmark to use would be to analyze your cost per patient visit. So the formula for that would be to take, it's a very simple formula, you take your operating expenses and you divide it by patient visits. What that leaves you is a break-even point. So in other words, to give you an example of that, in calendar year 2017, it shows that your total operating expenses were $360,000, okay? And that is before profit. So in other words, to keep your doors open, in order for you to meet your overhead, pay your salaries, pay your administrative costs, it was $360,000. You saw 10,000 patient visits or 833 patient visits a month. So if you took the 30,000 a month that it takes for you to operate your practice and divide that by 833 patient visits a month, your cost per patient visit is $36. That means that you have to make at least $36 on that patient in order for you to be breaking even, not even making a profit. Okay? Now, if you are let's say, a straight chiropractor and all you do are spinal manipulations and you have this kind of an overhead, your cost per patient visit is $36. And when you receive a fee schedule from Blue Cross Blue Shield that says the Blue Cross Blue Shield allowable is $35.15, you're losing money. Okay, that means that you are not going to make money as a participating provider with Blue Cross Blue Shield. And so these are things that you would have to take into effect. Now, if your cost per patient visit is $36, but your dollar visit average is, let's say, $50 a visit collected under those plans, that means you're making a $14 profit per patient visit, and that's okay. All right. And, there are going to be some times when you may be involved in a plan in which you're barely breaking even, and then you're going to have other plans in which you're making significant profit. And that's okay. I mean, you think about it. If you go to a grocery store, you go to a department store, there are certain ticket items in which they're barely breaking even. As a matter of fact, I think I read an article once where Walmart loses money on milk and eggs. They keep their milk and egg fees so low that they actually lose money on milk and eggs. But do people just buy milk and eggs at Walmart? No, they buy other things. And so the higher profits of other services or goods offset the loss. And so you may be in a situation like that where you have a patient population, or let's say you have an employer in your area that used to have Blue Cross Blue Shield, and they had a wonderful network. It was a great dollar visit average, and now they've changed plans at the beginning of the year, and now they're with United Healthcare. And United Healthcare has the $65 cap. And so you're going to be making significantly less money than you were. You really have to ask yourself the question, Do I want to get out of the United Healthcare network, or would it be a good idea to get into the United Healthcare network? Because if I don't and I'm out of network, am I going to lose all those patients? And one of the things that I've learned, if I can just give 36 years worth of words of wisdom, is that, and I tell doctors this all the time, is that insurance plans will come and go, but the patients will stay with you forever if you treat them right. And so you may have to suck it up and be involved in a plan that you just don't really like, that's not making you a lot of money. But if it allows you to keep your valuable patients, there is going to come a time when those patients either become maintenance patients and now you don't have to worry about their plans, or their employer realizes how bad the insurance is and they go ahead and change it at the next of the year. So don't let the insurance plans guide you whether you would want to accept patients under those plans or not. Because again, once you get them in the office, then what you do with them is up to you. And whether you're successful with that patient and can create a lifetime patient is up to you. It's not up to the insurance plan. And then you need to remember that. So some questions that you would want to ask yourself is, if you participate in a certain plan, would the reimbursement meet or exceed the cost per patient visit? Would there be a rise in clinic overhead that could affect your cost per patient visit? And if you participate in a certain plan, would there be an increase in patient visits that could affect your cost per patient visit? So, if you all of a sudden decide to get involved in a plan that has several thousand employees, a business in your community that has several thousand employees, you might see a really nice influx of new patients, but it also may require you to hire more people. And so you're going to have to take those things into consideration. After you've signed a contract with an insurance plan, it's important for you to continue to analyze the after effects of that contract. So how it's affecting your patient load, how it is shifting the payer mix in your practice, whether getting in or out of network with a plan is increasing or decreasing the patient numbers, the percentage of revenue that you're receiving from each plan, and so on and so forth. And so these are some of just some bullet points that you need to look at every month, or at least every few months, to decide if the contract that you've signed or the contract that you have gotten out of is having a significant impact on your practice. So to choose the different plans in your area, what you would want to do is analyze your patient base. You could print a report of patients by payer, look for changes in payers by employers that you routinely service. You might go to the Chamber of Commerce and obtain a list of employers in your area and look for employers that have over 20 employees. Then you can contact the HR department of that company and find out who their insurance carrier is for group health benefits. If you're thinking about getting involved in the VA, ask yourself whether there's a major veterans presence in your area, and is there a VA clinic or VA hospital in your area that would service the veterans that you could get involved with. And Medicaid, you would need to ask yourself the question as to whether Medicaid covers your particular type of health service, i.e. chiropractic care, and what percentage of your community's population is Medicaid. And some, believe it or not, there are some states that have Medicaid plans in which chiropractic benefits are reimbursed very well for Medicaid patients. And so it could be a plan worth getting involved with. Now, I do want to also talk to you about Medicare, and we're going to spend a little bit of time on this because I am constantly being asked whether it is worth it to be in or out of network with Medicare. And I've heard from time to time chiropractors tell me that they don't take Medicare patients. And I'm always a little bit baffled by that, frankly, because number one, chiropractors are not allowed to opt out of Medicare. So by saying you don't take Medicare patients, it worries me that that is actually the case, and not that, you are taking some Medicare patients as cash patients, or you're treating Medicare patients just as maintenance patients, which all of that is just a way of opting out that Medicare does not allow. And so you're not coloring within the lines at all by doing that type of a policy with your Medicare patients. But let's talk about Medicare. In the last 50 years, Medicare enrollment has increased 300%. And these numbers that you see on your screen, the 19.1 represents millions of people, okay? So in 2016, there were 57.1 million people enrolled in Medicare. And if you look at every year from 2000 to 2016, almost 20 million more people were enrolled in the 16 years. Now, I want you to think about this because people who are on Medicare are elderly, which means some die, okay? And yet, in spite of the mortality rates of the Medicare patients, there continues to be increases in enrollments. And the reason for that is we're living longer, okay? And so people are getting onto Medicare and staying on Medicare much longer, okay? In the 2 years between 2015 and 2017, 3 million more people were enrolled in Medicare. And again, remember, some of the people between 2015 and 2017 who had Medicare passed away. And yet there were still 3 million more enrollees and in that as an increase, okay? And so if you look at the Medicare fee schedule as an in and out of network provider, now what I'm showing you here is the national fee schedule for Medicare, which means that this would be the kind of national average of what you could expect to be reimbursed for chiropractic manipulations. Now, right at this time, Medicare only covers 3 codes, 98940, 98941, and 98942. As a chiropractor, you have 2 choices with respect to Medicare patients, and that is to either be an in-network provider or an out-of-network provider. You may not opt out of Medicare, okay? If you choose not to get a Medicare number or a Medicare PTAN number, which stands for Provider Transaction Access Number, then if a Medicare patient comes into your practice or ages into your practice, an existing patient who becomes eligible for Medicare, you must refer them out of the practice. You cannot see them, you can't treat them as a maintenance patient, nothing. You have to refer them out, okay? So the choices you have as a chiropractor is to be in-network or out-of-network. An in-network provider is going to receive 80% of the reimbursement, and in this case, the reimbursement for 98941 national average is around $41. It's actually one of the highest reimbursing insurance plans for chiropractic manipulation in the United States, besides personal injury, believe it or not. Blue Cross Blue Shield does not reimburse this high. Medicare is the highest in most states, the highest reimbursement for spinal manipulation in the USA. So what would happen is that the DC will receive 80% of this amount after the deductible, which would be $33.40 from Medicare. The patient coinsurance would be $8.36. And if the patient has a Medigap or a supplemental policy, they will usually pick up that $8.36. If you're out of network, you'll see that you can charge slightly more, which is called the limiting charge, okay? But the patient receives the reimbursement of 80% of the in-network rate, okay? So let me I'm going to just open up my drawing tool. So for an out-of-network provider, you can charge up to, let's say, $45.62 to the patient. You would collect 100% of that from the patient as an out-of-network provider. You would bill Medicare. You would not accept assignment. Okay, if you don't accept assignment, then what would happen is you've gotten paid, You still have to bill. This is one case in which you still must bill Medicare on behalf of the patient. The patient is going to be reimbursed, but they're going to be reimbursed 80% of this rate. So Medicare is going to pay the patient the same amount that Medicare paid you as an in-network provider, but the patient's coinsurance is the $8.36 plus the additional that you're able to charge as an out-of-network provider. So the patient has a higher out-of-pocket cost if you are out-of-network, okay? And so please be aware of that. Now, some out-of-network providers with Medicare also decide to accept assignment. And again, we're straddling the fence here, but here's what happens. If you're out of network with Medicare and you accept assignment, you'll receive reimbursement only on 95% of the limiting charge. You may not charge the patient the 5% difference, and that means that the 98941, the reimbursement would be based on 95% of this amount, or 4334. Now we're getting a whole lot closer to the in-network rate. Is really not much of a difference, okay, a little bit over $1. So the patient coinsurance in this case would be $8.67, okay? The patient coinsurance as an in-network provider is $8.36. Your reimbursement as an in-network provider is $33.40. Your reimbursement as an out-of-network provider who accepts assignment is $34.67. I mean, honestly, is it worth the 27, the $1.27 more per patient to be out of network? I don't think so. I think if you're going to take Medicare patients, you need to decide to be either in network all the way, all in, or out of network and do not accept assignment, and collect that full $45.62, because that is a little bit of a higher reimbursement for you. That's going to be almost $4 more per patient that you can make. But if you accept assignment, that $4 is reduced to practically nothing. So that's definitely not the direction that you would want to go. All right, let's move on very quickly. I know we don't have a lot of time left, and I'm just about at the end of the presentation. If I can get my slide to move forward. There we go. Another reason for considering that to enroll in Medicare is that there is a Senate bill right now in Congress that is proposing Medicare health plans for everybody. So in other words, they are looking at replacing Obamacare with an all-inclusive Medicare plan. This was just introduced onto the Senate. It actually makes a lot of sense because you don't have to rewrite policy, okay? All you have to do is adopt it and just say, we're going to make this available to everybody. We're just going to make Medicare available to everybody, and patients will have to pay a premium to have government Medicare. All right, and so this is called the Choose Medicare Act. It's proposing to use an initial funding of $2 billion to offer Medicare e-plans to any consumer. I believe this is the wave of the future. I think if this doesn't pass this round, it's going to come up and come up and come up until Medicare is available for all ages. Okay, so another reason to get ahead of the game and make sure you're a Medicare provider is because Medicare may be available to everybody. The other thing that is going on with respect to Medicare is that right now it is in committee with the Medicare Review Committee at CMS for chiropractic services to be expanded to include all services, meaning exams, x-rays, therapies, extra spinal manipulations, and this is called the National Medicare Equality Petition. This petition has been completed and it is now in committee, and I just spent the last week at the Virginia Chiropractic Association. Dr. Tuck, who is a chiropractor with the Virginia Chiropractic Association, is the new president of the ACA. And I spoke to him and I asked him about this, and he said, and I asked him and several other doctors who were at the VCA who are highly involved in this National Medicare Equality Petition, as to what the likelihood is that Medicare is going to be expanded in the next couple of years to include all services that chiropractors perform, and they believe there's about a 90% chance of this happening. And so that's great news for us, but you have to be in a position to be able to accept these Medicare patients. And I tell you what, if chiropractic is expanded, all these doctors who are not in Medicare are going to want to jump on the bandwagon, and it may take you months and months and months to get enrolled in Medicare if and when this happens. So in a nutshell, remember that Medicare is the fastest growing population in the USA. You need to think of the short and long-term new patient impact. There is a possibility that Medicare will be available to anyone. There's a real possibility that chiropractic coverage will be expanded in the next few years to include all services, and there's very little difference in reimbursement as a par versus a non-par provider if you decide to accept assignment as a non-par. And remember that you may not opt out of Medicare. So, as far as managed care contracts go, the things that you would do when you are trying to get involved in a managed care contract would be to gather information about the contract, make an acceptance to the contract, and then make an intention with that carrier to create a legal relationship with them. And these are some of the main items to consider, and we talked about this earlier in the presentation. You also would need to find out from the provider relations rep if you're looking at getting involved in an insurance contract. And again, we're not talking about Medicare anymore. We're talking about the commercial payers. Are there areas of the contract that are negotiable? Can you negotiate the fee schedule? Can you negotiate the terms of the contract? Or if you're going to be placed in a certain tier, so for example, let's say United Healthcare tiers providers from a tier 1A plus to a tier 4 provider. And depending on what tier you're placed in initially, you may or may not have to get pre-authorizations for services. So if you can negotiate to come in as a tier 1 plus and say, look, I'll come in to the network as a tier 1 plus, and I don't want to do all the pre-authorizations. Okay, I know that is a negotiable term, and depending on the need that United Healthcare has for providers in the area, they may agree to that term. If there's a high demand for chiropractors to join that network, they may put you in a higher tier in order to get you into the plan. So make sure you contact the payer and speak to provider enrollment and find out if you do want to be contracted, find out if they're accepting new doctors in your area. It's called Lines of Business. Ask to see a copy of the contract and the fee schedule, and ask if there are any areas or provisions of the contract that are negotiable. If you do need help with credentialing or becoming in or out of network with a plan, you can contact us. We do have a dedicated credentialing service for doctors that has nothing to do with our billing services, and so we provide that as a standalone service. So if you're interested, contact me, and I can give you the particulars on getting credentialed with certain plans. So what I'm going to do is very quickly, I'm going to unmute everybody, and I want to see if we have any questions. I don't see any questions in the chat box. Do we have any questions before we finish the presentation? Okay, I'm going to assume that there are no questions. And so what I'd like to do is, I know Dr. Fennell, I think he had to step away for a meeting, and just told me that I could let you all know that, number one, I appreciate your listening in on this presentation today, and I wish you all the best. If you do have any particular questions about whether to participate or not participate in a certain insurance plan, don't hesitate to give us a call. Dr. Fennell has my information. Of course, it's posted here on the screen as well. And I would like to thank you all again for participating in this webinar today, and have a great day.